The next complicated alcohol withdrawal syndrome that we are going to discuss is delirium tremens. So as mentioned before, delirium tremens or alcohol withdrawal delirium, the usual time when delirium tremens appears is about 3 days after stopping alcohol. It lasts for about 7 to 8 days or even more. Usually it lasts for about 2 to 3 days or 3 to 4 days after its onset. About 5% of patients who have alcohol withdrawals can have delirium tremens. Generally, delirium tremens is preceded by other signs of alcohol withdrawal. What is important to remember is that DT or delirium tremens is a medical emergency and it is a potentially life-threatening condition. So we should make every effort to prevent and manage DT. So what are the features of DT? So the first feature, as we discussed before, is that there should be a long history of almost daily regular use of alcohol and heavy amounts of alcohol use in the recent past. Following with sudden stopping of alcohol, there will appear some symptoms. What are those features? One is the usual symptoms of alcohol withdrawal that we saw in the previous session, which is tremors, anxiety, restlessness, insomnia, increased in blood pressure or fluctuation of blood pressure and heart rate, fever. Along with these withdrawal symptoms, other set of symptoms which are delirium. What is delirium? Where there is disturbance in consciousness. The person will be disoriented to time. So when you ask him what time of the day it is, for day he may say it is night. He may not be able to tell, or he may tell wrong date, wrong day, wrong year, wrong month, so on and so forth. He will be misrecognizing the place. So for example, if he is there in your clinic, he may say that he is in his house or he is with a friend at a friend's place, etc. He may also misrecognize persons around him. So he may call his brother by some other name, he may call his son or wife by some other name. So this is what is disorientation to time, place and person. Along with that, he also will have perceptual disturbances. So typically he may have illusions. What are illusions? So for example, if there is a crack in the wall, he may think that these cracks on the wall are actually snakes slithering on the wall. Or if there are small dots on the floor, he may think that these are bugs crawling on the floor of the clinic. The person may also have hallucinations where there is nobody in front of him, but he may see small persons standing in front of him, what are called as Lilliputian hallucinations. The person may also become fearful because of this, and he may also be agitated. So presence of delirium, perceptual disturbances and alcohol withdrawals in the backdrop of stopping of alcohol following long history of regular use and heavy use in the recent past are clinical features of delirium tremens. Now, as in the case of alcohol withdrawal seizures, presence of delirium alone in the backdrop of stopping alcohol use does not mean that the person's diagnosis is delirium tremens. Delirium can occur due to various other reasons in a person who is using alcohol on a regular basis. It may be, like for seizures, hypoglycemia, hyponatremia, hypokalemia. It may be secondary to trauma sustained while he was intoxicated with alcohol. It may be some other reasons. So we also should keep that delirium can happen because of other causes. This slide shows some differences that can act as a differential between delirium due to other causes and delirium tremens. So DT is usually a hyperactive kind of delirium vis-a-vis delirium due to other causes which are hypoactive or mixed variety. Other comorbid conditions are usually there in delirium due to other causes. In DT, sometimes it will be there. DT usually has a better prognosis as compared to other delirium. DT is expected to recur in the future if the person does not stop his alcohol use, where the person may have severe episodes of alcohol withdrawal, or he may have DT. So past history of DT is a predictor for future episodes of DT. In terms of management, in case of delirium due to other causes, it is better to avoid benzodiazepine and treat the primary etiology. In delirium tremens, benzodiazepines are the treatment of choice. Hence, we should make every effort to distinguish between delirium due to other causes and DT. Of course, the differences that have been presented here are indicative and not applicable for each and every case of delirium or DT. So what are the risk factors for delirium tremens? A high CYAR score of more than 15. Recent withdrawal seizures can also be indicative of delirium tremens to happen in the future. So in 20% of patients with delirium tremens, they'll have recent alcohol withdrawal seizures. Prior episode of delirium, DT or seizures, they also are risk factor for future delirium tremens. Recent misuse of other depressant agents such as benzodiazepines are also risk factors for delirium tremens, or presence of other medical problems like electrolyte abnormalities, low platelet count, or concomitant respiratory, cardiac or gastrointestinal diseases are also risk factors for delirium tremens. So how to assess for delirium tremens? As discussed in the previous session, how to assess for alcohol withdrawals, those all steps must also be followed for DT. That is, we need to take a proper history of alcohol use, establish alcohol dependence, conduct a thorough physical examination as well as a detailed systemic as well as neurological examination, rule out other medical conditions, especially head injury, hypoglycemia, electrolyte imbalance, liver failure, pancreatitis, GI hemorrhage, meningitis, etc. to rule out other causes of delirium rather than ascribing delirium to DT alone. After your history and physical examination and systemic examination, apply CYAR as discussed in the previous session. Look for presence of alcohol withdrawal signs. Then check for delirium. How do we check for delirium? We assess his attention and concentration. So one may ask the patient to subtract 7 from 100, then next minus 7. So serial subtraction of 7 from 100 or serial subtraction of 40 minus 3, 20 minus 1, depending upon the level of individual's education and understanding, or simply one may ask the individual to count backward from 20 to 1. If he is not able to perform this task, that means he has impaired attention and concentration. Also, check for his orientation. Ask what time of the day it is, which day is it, what is the date, what is the month, what is the year. For checking orientation to place, ask which room number is he in, which floor is he in, name of the hospital or clinic, name of the city or town. So if the person has impairment to place orientation, then he will not be able to name this. Similarly, for checking orientation to person, ask him to identify relatives or attendants who have come with him during the assessment. So if the person's orientation is impaired, so orientation to time, place of person, we will be able to understand this. If the person has impairment in attention concentration as well as orientation, along with alcohol withdrawals, one may keep a diagnosis of delirium tremens provided other causes of delirium have been ruled out. Now, what are the investigations that one must consider in assessment of DT or management of DT? So one should order for a complete blood cell count, do a baseline metabolic panel in terms of serum electrolyte, blood glucose level and renal function test, conduct liver function test, if possible conduct a blood alcohol or urine toxicology studies, but this is not essential. And if one suspects other causes of delirium, one may order even a brain CT or MRI as advised or indicated. So how does one manage DT? It is important to remember that DT is a complicated alcohol withdrawal syndrome case, and in such cases DT should be managed in inpatient setting alone. Such patients cannot be managed on outpatient basis